Good afternoon. I'm encouraged by the great attendance this afternoon. So welcome to this industry lunch symposium entitled Second Generations Biolimus Drug-Coated Balloon in Clinical Practice. This is sponsored by Bio ASCEND ISR International. My name is Tan Hui Chim from the National University Heart Center in Singapore. And as an anchor person with me is Professor Dr. Chin Chi Tang also from Singapore. And we have two discussants with me, Dr. Jiang Jin from China and Dr. Tay from IJN in Malaysia. So before I go further, I just want to remind you that we do have actually a poll questions here. So if you can just take out your handphone and download the app, you can actually participate in the poll questions that we're going to be having. To start out with, let me just go through this afternoon's session's objectives. The session objectives are to understand the role of limus drug-coated balloon in modern interventional cardiology. Number two is to receive the latest clinical evidence of limus versus paclitaxel-coated balloons from the Bio-Ascend in-stent restenosis study, which we'll be presenting, and actually already presented as a late-breaking trial. And also learn about practical experiences on the use of a limus drug-coated balloon in small vessels and de novo coronary lesions. So to start the sessions going, I'm going to start off with the poll question number one. So somebody can just poll the first questions. And so if you could take out your handphone and answer this question of what type of DCB are you currently using in your practice? Paclitaxel only, limus only, or both? Whoa, 100%. Oh, no, wait. One minute. Okay, so voting's close, pretty close. Half of them use paclitaxel, 45% majority actually have both types of drug-coated balloons. Oh, very nice. So let's go to poll question number two. When treating ISR lesion, what factor would you consider the most crucial in selecting DCB as the preferred treatment modality? Is it the type of ISR lesion based on clinical evidence or the potential for repeat intervention in the future? Very nice. I think a majority of you are evidence-based people, so 55% will select DCB based on clinical evidence. So to start the ball rolling, I'm going to invite Dr. Gao Lei to present to us the Bio-Ascend ISR study, the clinical outcome at 1 year.
Whilst Dr. Gao Lei is getting ready, so invite everyone. If you will have lots of questions, so please feel free to use the app and post your questions so that we can address them later. Thanks.
Yeah, dear Chairman, dear Pat, I'm Lei Gao from Chinese PLA General Hospital. It's my great honor to stand here to present the Bio-Ascend ISR study just published in your intervention last day. I don't have any potential conflict of interest to declare. So, in-stent restenosis, just particularly with the use of drug-eluting stents, is still a big challenge in clinical practice. The study was conducted to investigate the novel biolimus-coated balloon for the treatment of coronary DSSR compared with the best investigated PCB. The test device of biolimus A9 coated balloon and it newly improved drug formulation and coating technology. It minimized the drug loss and enhanced the rapid absorption by tissue during delivery. The study was conducted in China in 17 hospitals. The study was multi-center, randomized, controlled, single-blinded, non-inferiority study conducted at 17 hospitals in China. And the primary endpoint is in-segment late lumen loss at 9 months. And we used OCT subgroup for the major secondary endpoint, that is a new intimal area at 9 months. Because we designed with non-inferiority against the sequence please new balloon, so the sample size we reach up to 280. This is the study key inclusion criteria and key exclusion criteria. 280 patients underwent randomized in the study, and 5 patients withdraw consent after randomized. Then, in BCB group, 138 were included, and the PCB group, 137 were included. Finally, almost 80% patients finished 9 months angiography follow-up, and during 1 year clinical follow-up, almost 100% patients finished the follow-up. Next, I will introduce the baseline characteristics. For demography and clinical characteristics, there is no significant difference between 2 groups. And for lesion characteristics and ISR type, also no difference between 2 groups. For procedure characteristics, predilation technology, no difference between 2 groups, and the mean diameter and the total length of DCB, also no difference. For procedure characteristics and the results after post-procedure, the successful outcomes included device success, lesion success, and procedure success, almost 100% in both groups. Next, I will introduce the primary results of BIO ASCEND ISR trial. In this trial, the late lumen loss for biolimus-coated balloon was 0.25, and the PCB group, the late lumen loss was 0.27. So, for absolute difference between 2 groups was negative 0.02. Achieved non-inferiority of BCB compared with PCB. There were no difference in the cumulative percentage of lesions of late lumen loss between the 2 groups. For the major secondary endpoints in OCT subgroup, the average new tumor cross-section area was almost normal, almost similar between 2 groups. That is QCA results. Pre-procedure, both groups, the result was similar. And post-procedure, the diameter stenosis in BCB group is relatively higher than PCB group. But 9 months follow-up, in minimal lumen diameter stenosis and the late luminous, there was no significant difference between two groups. For clinical outcome, at 1 month, no difference between two groups. However, at 1 year, the target lesion failure and the target lesion revascularization in biolimus-coated balloon group relatively higher than PCB group, even though no significant difference. The clinical trial reveals that for patients dealing with coronary DSIR, the use of biolimus-coated balloon was non-inferior in terms of angiography outcomes at 9 months compared to a well-established PCB. A higher number of revascularization events was seen in the biolimus-coated balloon group at 1 year. Due to the unique pharmacokinetic profile of lemurs, long-term follow-up is needed to establish the clinical efficacy of these technologies. That's the event essentials to remember for this study. And the study results were simultaneously published in EuroIntervention. That's all. Thank you so much.
Thank you very much, Dr. Cao. Thank you very much. So I think this is a very important trial because it shows a head-to-head comparison of this new biolimus-coated balloon versus something that we know very well established as a paclitaxel-coated balloon. So head-to-head trials shows that this BCB is non-inferior. That's good in terms of late luminal loss. But clearly we can see also that there was numerically a slightly higher number of patients with target vessel revascularizations at 1 year. So maybe perhaps Dr. Cao can tell us why is there this numerically higher number of TVR when your late luminal loss is the same?
Thank you, Professor Chen. I think this problem, when we submit the manuscript to the EuroIntervention, the reviewers also ask the same question. We talked with our PI Yundai Chen professor in the same hospital, and we talk about with the other principal. I think maybe two reasons can answer this question. The first is, in the study, we designed with angiography outcome as the endpoint. We didn't use clinical endpoint for this study. So maybe the sample size cannot answer the clinical outcome between the two groups' results. Maybe random results can occur. Another possibility is because the lemurs DCB, I think the absorption and the duration of this kind of drug is different from paclitaxel. So long-term duration follow-up would be needed for answer the question. Thank you.
So, Jiteng, this is yet another sirolimus-coated balloon study telling us increasingly that the result seems as favorable as that of paclitaxel-eluting balloon. Just looking at the landscape right now, how do you see this limus-coated balloons coming on?
Okay, so, okay, thanks. That's an incredibly tough question. So it's limus versus paclitaxel here. So I think the short answer to this is I don't think it's that simple. It's not limus versus paclitaxel. I think we've had a few trials now looking at the different formulations, and I think it also depends a lot on the design of the balloon. So we've got studies that have shown, when you compare sirolimus-coated versus paclitaxel-coated in ISR, for instance, the magic touch did not perform as well as the sequin-please neo in the transform study, while the sequin-please sirolimus-coated balloon was able to prove non-inferiority. So I think it depends a little bit on the balloon design itself. And even with the biolimus-coated balloons, last year was presented, was not able to meet non-inferiority, but that was a slightly different design from the one that was used in Professor Kaule's study. So I think we still need a lot more data. I think it's safe to say that both the formulations are safe. It's really about the longer term and where we're going to place them in our armamentarium. Yeah.
I'd like to welcome any comments from the floor as well, so please.
Thank you for this. Is it working? Thank you very much for this interesting study. I think generally speaking, it's beginning to be a problematic in our designing of studies. I'm not sure a non-inferiority design in these cases are the best option. We're starting to do more and more non-inferiority. Non-inferiority studies means we accepting that the new device or the new medicine is a little bit worse than the one we're using. And that's only justifiable when there is a huge difference in practicality, like PCI versus surgery or something like that. But in two devices, where it's the same device, it's balloon with medicine, I'm not sure non-inferiority design is the best option.
Well, non-inferiority design has his advantages as well in terms of, because it's very hard to prove superiority in terms of outcomes over a established product. And that one you need huge sample size. So non-inferiority gives you certain advantage in the sense of initial efficacy and probably safety as well. Gentleman at the back.
Yeah, Philip Urban from Geneva, Switzerland. Just one question. Last year at these sessions, the same company presented some somewhat disappointing results with the reform trial. And now you're showing us a biolimus DCB, which has very satisfactory results. Would you speculate or explain to us what the difference are between the devices, if any?
Dr. Carr?
Yeah. I notified you talk about the reform study last year published in EuroPCR 2002-3. In reform study, the results showed biolimus-coated balloon was not equally the same results with PCB. However, in this study, we have the different results. So we talk about, when we think about this question, we compared two studies. Reform study was designed just 6 months follow-up. It's the first difference. The second one is the reform study included BMS or DS ISR in the including criteria. However, in this study, we just included DES ISR patients. This is the second problem. The third one is in this study, the sample size a little big than the reform study. The fourth one is even though the drug the same, biolimus. However, different company developed the biolimus-coated balloon. This study used the BA9 balloon, the same as the same as BioRise China study, just published in JACC Intervention 2020. This is the same company device. So different device may be the reason for that. I think so. Thank you.
Yeah, so I think just to add on, I think the crystalline formulation is slightly different. Drug is the same. So, alludes to my initial comment about maybe it is something to do with the design. It's not as simplistic as, A versus B. Yeah. If any other questions from the floor, these are great. Anyone? So feel free to use the app or just approach one of the mics. Yeah.
Thank you very much, Dr. Gao. We would like to go on to the next speaker here. I'd like to invite Dr. Tsai Guangyao to tell us about his topic on redefining indication for use of drug-coated balloon, his own protocol.
Thank you. Thank you very much, esteemed colleagues, esteemed panel. I'd like to report a case. It's a case of a lot of uncertainties. I'd like to share with you to hear about your ideas. It's a case of OCT-guided treatment of DCB, the Bio-Ascend for the proximal LAD de novo lesion, and some follow-up all the way to 19 months. I have nothing to declare. The patient is a young patient, only 38 years old, but with a lot of risk factors like hypertension, diabetes, hypercholesterolemia, smoking, a lot of things. And the patient has got symptoms for 2 years and already has 2 stents implanted at LACX and RCA. And the patient's risk factors are not very well controlled. So in the months, exertional angina was experienced and another angiography was performed to find diffuse lesion with some degree of calcium in the LAD. But the stents in the LCX and also in the RCA are okay. So the problem is in the LAD, which is very definite, and the patient, for some unexplainable reason, maybe some unpleasant symptoms during the last procedure, refused cabbage and refused stenting very strongly. So not another stent can be inserted in my body. Again, so in that scenario, can we use DCB for this lesion? So this is our question. So this is a pre-OCT with angiogram. As you can see, the lesion was severely stenosed, only MA only 1.71 millimeters squared, and FFR is only 0.59. So the patient is undergoing severe ischemia, that's for sure. And we can see from several segments the lesion in the most severe part is only 1.71 millimeters, so the area is very small. So you have to do with it. But as we can see from the OCT, as well as lipids and fiber, we can see a lot of forming calcium in the progress. The calcium is forming because of the diabetes, I think. So can we do that? So in this, the lesion is very diffuse. We can't find a relatively healthy segment as a reference. So we must use the relatively healthy. As we can see in the distal part of the most severe lesion, we can see the reference diameter is set to be 2.5. So we introduce this protocol is entirely based on experience, not clinical evidence. So what do we do? We dilate with a 2.5 Wolverine cutting balloon, but very, very slowly and up to 14 ATM, inflating and deflating at a very small pace, 1 ATM per 2 to 3 seconds, very slowly. So we inflate to 14 and deflate to 0 with the blood flow blocked for about 60 seconds per round. And we do this round for 2 to 3 times based on the residual stenosis. So it very slowly inflation. And the interval time of 30 to 60 seconds between the rounds, the dilations to restore the blood flow reperfusion. And after 2 to 3 rounds, we use biolimus-A9, the Bio-Ascend drug balloon to 8 ATM for 6 seconds. So the whole procedure, the whole pre-treatment procedure lasts around about 30 minutes or so. And after that, we do another OCT. And as we can see, massive diffuse dissection, both antegrade and retrograde appear, and with the MLA go up, improve to 3.55 millimeters squared, as we can see from every segment. And in the distal part, maybe some change due to nitroglyceride to alleviate the spasm something. But as we can see from the most severe part, this is a calcium protrusion and some kind of dissection in the bifurcation area, and also in the most severe part, the 1.71 improved to 3.55 with the consequences of massive dissection, and also in the proximal part we can see massive, very severe dissection. So based on current consensus or guidelines, we should implant stents because to avoid the abrupt closure. But can we not? Can we go without stent? That's the question. So the patient is still very strongly feel, so we are trying very best to avoid the stent implantation. So in this scenario, how can we be sure later in the future the vessel, the hematoma won't extend to cause abrupt closure of the vessel? So that's what we're trying to answer. So now here we do another physiology evaluation. We can see the FFR is 0.78, somewhat acceptable maybe, but what about the hematoma? Will it extend? That's a question. So what do? After DCB treatment, we do the first OCT, very forceful. We try to induce dissection hematoma formation. We try to do that as if, so we do that and FFR is 0.78. After 15 minutes, with no symptoms whatsoever, we do another OCT, very forceful flush, very forceful. And the patient, no symptom. At the time, we can see from the axial imaging of the OCT, no apparent dissection extension. Also, the MLA is no different. Also, the FFR may be more subtly to capture these subtle changes of the hematoma. 0.75, no significant change. And on another 15 minutes, after half an hour after the procedure, we do another forceful flush. Still no apparent. At that time, instead of waiting, we do several flushes to make sure the dissection won't grow or won't extend. This is our protocol. So okay, go. So after half a year, 6 months, we do a follow-up. As we can see, the flow is okay, and the FFR is 0.85 at the time. The patient's symptoms never reappeared. We do another OCT, and as we can see, the healing of the dissection is healing very nicely. So that is very satisfactory, and we can see the area, the lumen area, has all improved overall. So this is a comparison between the pre, the post, and also the 6 months follow-up. As we can see, the lumen area seems satisfactory, and the patient is also very happy because no another stent. And we can see we are still follow-up, but in April this year, 2024, after a 19 months follow-up, we can see the angiogram is somewhat okay, but the FFR is 0.79. Seems ischemia situation or the physiological deteriorating maybe. So we do another OCT, and as we can see from the comparison, the 1.71 area, the most severe lesion area, reappear. The lesion seems to reappear at the same spot, but this time with massive calcium masses, calcium protrusion to squeeze it lumen as it was. So we can see the patient's diabetes, the patient blood sugar level is not very well contained. So maybe that's some contribution to the calcium of the situation. But overall, we can see the DCB regimen, the DCB, our protocol works to help the patient lumen retain this area. So as a summary, maybe in this scenario, the DCB might prove an option in the treatment of de novo lesion in large vessel disease, in spite of the diameter only 2.5 millimeters in this case. And also, our protocol stresses the importance of multiple, very forceful OCT flushes over a period of no shorter than 30 minutes to induce dissection extension, which instead of dissection itself warrants stenting. So we don't want to wait. We wanted to induce this dissection, the hematoma, extension. But if we can see no, we can see not, we can be assured that no possible dissection may be induced. And also we want, Also, we want to recommend physiological evaluation as well as OCT because like FFR, QFR, something like that in the post-PCI 30 minutes, we call that the probation area, the probation period. We watch the period to maybe become stent warranted, but in this case, not. So our center has established a cohort of 31 cases so far, and so far observing no events, no MACE, no abrupt closure of the vessel so far, but the evidence is very weak. So we are still trying to do that, to build up the evidence. And more evidence is urgently needed to address the intervention with nothing left behind issue, because in China, people are more afraid of inserting things in our body than maybe other cultures. So this is a very urgent issue. And maybe DCB can help us fully realize, can address this issue. And DCB, we should fully realize the potential of DCB in modern PCI. So we are still trying to keep pushing the boundaries to do that. So this is a lot of uncertainties. Thank you for your time. Thank you.
Thank you very much. Thank you for sharing with us a very unique protocol to use DCB in de novo proximal large epicardial coronary vessel. So to just summarize, you do a pre-deal with a balloon. Then if your results is good, less than 30% residual stenosis, you take a DEB and then you dilate. And then you wait for about 30 minutes. And during this 30 minutes, you will do a forceful injection of the contrast with OCT as an image guidance, followed by also some physiological guidance. And at 30 minutes, if it's good, then you quit. And so that will be the protocol. But if the dissection gets worse during that 30 minutes or physiologically got more ischemic, then you will consider stent. Okay, so that will be a new protocol. So Dr. Jiang, what do you think? Dr. Jiang, do you think this approach is good for common lesions? You think it's good for ACS, it's good for calcified lesions? And how do you think this strategy or this protocol actually work?
So I think it's quite interesting protocol, but we need more data. Up to now, they have 31 cases. It sounds good, but personally, I'm a little bit worried about, if you repeat the OCT, you may actually propagate the dissection. Personally, I prefer FFR guidance. So if it's FFR is greater than 0.8 and with TIMI-3 flow, we can end the procedure. So that's my personal thinking.
And Dr. Tay, what do you think? A DCB replacing coronary stent for de novo coronary lesions? I mean, we came a long way of proving that stent is superior to balloon angioplasty. Now we're going back again to balloon angioplasty, but this time differently with a drug-coated balloon, granted. But what do you think has changed in the landscape here?
Right, thank you very much. So I think this boils down to the recent concept of people preferring to leave nothing behind, right? So I think many years back, the idea was if you put a stent, you are mentally secured that the vessel patency is preserved by the stent. But nowadays, I mean, coming from Malaysia, and it's a little country with the highest number of diabetics in the region. So we have patients who present with very ugly-looking vessels, very ectatic vessels in the proximal LAD and such. So I feel like DCB offers a choice where, in patients where stents are probably not suitable or going to be suboptimal, DCB actually is one of the better options. And also in cases where there were some apparent complications, for example, like Dr. Zai's case, where there was a significant dissection, which conventionally I think most of us would have stented the lesion. But DCB proved that it actually healed the vessel, and the final outcome of the few months was quite acceptable. So I think this is something that is a changing landscape, and it is actually something to look forward to.
Thanks. We're getting some questions coming into the chat, which is very exciting. So maybe I can direct to Dr. Chai. If in your case there's a large dissection plane, So does that modify what you do thereafter? What's your DAPT regimen? Do you bring them back earlier? Can you explain to us? Yeah.
Yeah, thank you. So I think when dealing with these kind of lesions, you roll the dice, right? You roll the dice. You have to trust your guts sometimes. So we do our very best to mimic what the future blood flow would do to the dissection. But still, with with multiple forceful flushes, you still can't really to realize the damage the blood flow might do to these dissections. So we do our best to predict. So when, in our 31 cases of successes, there's also like 10 cases of stenting. 10 cases of stenting. But when with the 30 minutes of probation period, we do a lot of OCT forceful flushes, but sometimes we can see very evident hematoma extension during our pushing of the OCT contrast. So at the time, we have to use very experienced operators to do the OCT because you have to stop. You have to stop during your flush and you do the stenting. So if the dissection extends, we do stenting, of course. But if the three flushes did not prompt any dissection extension, I think it is relatively safe to say the dissection won't extend in the future and is better validated than just wait to see whether or not, no matter 30 minutes or longer. So I think this approach might pose a larger threat to the dissection. So I think this is a very interesting idea to do that. Thank you.
Actually, if you are performing OCT, you can actually use OCT to predict the severity of the dissections here and see whether it can actually result in complication. So OCT, when you have an angle of more than 60 degrees, or when you have a deep dissection in the medial, or you have a long dissections beyond 2 millimeters, all this portends a poor outcome as far as the dissection goes. So if you are using OCT, perhaps that can also be a parameters to guide your decision. So I'd like to go on to poll questions number 3 and see what the audience say. Thank you very much, Dr. Zhang.
Thank you.
So I'd like to ask the audience, besides ISR, which type of lesion would you consider the use of DCB in your practice? Small vessel, bifurcation, STEMI. Okay, majority will use DCB for small vessels, followed by bifurcation. Go to question number 4. In your practice, what percentage of de novo lesion cases are currently being treated with DCB instead of DES? Are you using DCB for de novo lesions? I think the huge majority do not buy the concept of DCB and de novo lesions for the time being. But anyhow, we will take these questions and answers to our next speaker, Dr. Dasto Antonius from Indonesia, to tell us about his use of Bio-Ascend in his real-world practice in Indonesia.
Thank you, Professor Tan, for the introduction. Ladies and gentlemen, my name is Dasdo. I'm working currently in the hospital, Awadros Hospital in the city Pekanbaru. It's 2 hours flight from Jakarta. Thank you, Bio-Ascend, for inviting me in this prestigious session. I would like to share some of my experiences using Bio-Ascend. It's a biolimus-coated balloon in our center. Drug-coating balloon has been introduced and marketed in Indonesia for the past over 15 years, and just recently, biolimus-coated balloon was marketed in our country for the past 1 year. However, the adaptation of usage of the drug-coated balloon is quite low nationwide because of several factors, and most importantly, it was because of the reimbursement, which was not covered by our national insurance scheme. And for some reasons, which we can't really understand why, drug-coated balloons can cost higher compared to the drug-eluting stents. Personally, I've already used a drug-coating balloon in several clinical situations, but also still face some challenges coming down from the morphology of the vessel itself, as well as sometimes whether I have got to leave some dissection alone or not. My first case was a 45-year-old gentleman presenting to us with non-STEMI. He was diabetic and also had some other risk factors. It can be appreciated here that he had occlusion at the ostial part of the diagonal. My upfront strategy was to perform not leaving any metallic stent in the lesion. So I prepared the lesion with a 2.5 millimeter compliant balloon and then treated it with a 2.75 biolimus-coated balloon. This was the final result. Just recently, I received a patient with lateral STEMI. Following the fibrinolytic, he was referred to our center. Also had some significant lesion at the diagonal, also treated with biolimus-coated balloon, and we could appreciate here that we achieved quite significant acute gain with good distal telemetry flow. Secondly, was a 54-year-old male patient with STEMI, progressive chest pain, and he was quite sick upon the presentation because he also had acute heart failure with ejection fraction of 30%. He was diabetic and had several other risk factors. It turned out that the patient had triple vessel disease, turning down bypass surgery. After quite intensive discussion with the patient and the family per se, they only opted for coronary angioplasty. The proximal part of the LAD was significantly diseased, and also some diffuse atherosclerotic plaque at the distal part of the LAD. So I planned for hybrid angioplasty with IVUS guidance, and eventually, I implanted one biofreedom stent proximally and treated the distal LAD with a Bio-Ascend 2.75 with distal reference diameter by IVUS was 2.6 up to 3.0 millimeter. I had the chance to perform a recoro to this patient for 4 months following the procedure, and we can see here that there was like a positive remodeling following the drug-coated balloon angioplasty at the distal part of the LAD. My third case was a 57-year-old female patient with STEMI, ECG showing Whelan type syndrome, diabetic, hypertensive, and also had dyslipidemia. The proximal part, I think it also involved the ostial part of the LAD, and some part of the distal part of the left main had significant disease. Distal circ was significantly stenotic, as well as the mid body of the LAD. Also, I performed a hybrid approach to this patient. Firstly, I treated the distal circumflex artery with a biolimus-coated balloon after preparing it with 2.5 millimeter compliant balloon. I treated with a 275 millimeter biolimus-coated balloon. The dissection at the end of the procedure was appreciated. And meanwhile, the mid part of the LAD was treated with also Bio-Ascend, biolimus-coated balloon 2.5 by 25 millimeter. My last case is a rather intriguing patient, a 63 years old male patient presenting to us with stable angina with prior positive treadmill test and also positive coronary CT scan. He was not diabetic, but he had hypertension and hyperlipidemia. As anticipated by the prior coronary CT examination, we could figure that the proximal part of the LAD had severe stenosis, mid-body of the LAD had myocardial bridging. Meanwhile, the distal part also got quite significant atherosclerotic plaque. As such, with the extension of the lesion, I performed another imaging-guided coronary angioplasty, just for us to get to know what to treat and how to treat the lesions. The moving image at the right side showing us that at the part of the myocardial bridging, there was no significant, I think at most, it's only very mild atherosclerotic plaque at the myocardial bridging. So I also performed a hybrid strategy to the patient. Approximately 1 DES was implanted, and I prepared the distal lesion with a 2.5 scoring balloon, and also eventually with a 2.5 non-compliant balloon before putting down the Bio-Ascend biolimus-coated balloon to the distal part of the LAD. These were the final images of the LAD. And if you want to make comparison, the left side, it was the coronary angiogram before, and the left side of was the coronary angiogram following the procedure. So ladies and gentlemen, drug-coated balloon could be considered in both stable and acute coronary syndrome patients, but particularly as supported by the evidence, I personally mostly performed applied the device for small vessel and side branches. And imaging is pretty helpful because it would help us to determine the vessel size and to get to know the morphology of the lesion, and also to find out other anatomy abnormalities. The benefits of performing such hybrid strategy, DS plus DCB, for me, most importantly, for the LAD lesion particularly, is to give the patient future possibility should a bypass surgery be needed. Thank you very much.
Thank you very much, Dr. Dasso. So it would appear to me that DCB is quite kind of widely used in situations where you don't want to put in stent, in side branch, in small vessels, in the hybrid procedure, and so forth. So all those indications are off-label at this point in time, and the only on-label indications for DCB is in in-stent restenosis. So Chideng, so how do we go about looking at something that has been labeled off-label, and yet in real-world clinical practice it is being used widely in small vessels and so forth?
Yeah. So. Well, the short answer to that is we just need to wait until we gain more evidence, and I think that actually is coming. Having said that, it's not totally evidence-free. I think we have quite a fair amount of data now accruing, especially for small vessels. Granted, most of the RCTs looking at drug-coated versus drug-coated balloons versus DS are, as our colleague mentioned, non-inferiority studies. But having said that, they have shown in most of these published series that they don't lose out to DS. And I think from a practical day-to-day point of view, using a DCB in addition to all the advantages that Dasdo mentioned is for most of us, it's easier to use a DCB-based strategy, right? It's easier to deliver the stent. You get away without encasing or caging that vessel. So I think there are practical benefits to it. I think the data is accruing, and I think the indications are going to start expanding as well. We're now having studies that are looking at larger size vessels. I know of a few ongoing studies looking at large vessels, addressing the proximal segments as you mentioned before. So I think it's a very exciting space. I think that's why the room is full, and I think we are going to learn much more in the future.
Yeah, I recall actually a very small trial, PET bifurcations comparing to DCB versus POBA in side branches. And it turned out that the angiographic follow-up, the late luminal loss was lower with the DCB compared to the POBA, and the binary restenosis was obviously lower, but it's actually, this is angiographic, there's no clinical outcomes and so forth. So maybe I can ask Dr. Tay, so then what is your considerations? What would you consider in your practice to use DCB?
Right. Thank you very much for the question. So first off, I think there's a big difference in terms of practice across the world. Like from where I come from, we do use a lot of DCBs in de novo lesions. Echoing what our chairperson has mentioned, we use it in small vessels, sometimes bigger vessels, up to 3.035. Now, I think mainly for me, the idea of having DCBs available is most valuable when we talk about vessels that are not healthy, where there's a lot of diffuse disease, where there's no proper landing zone to put a stent, or when we consider that patients will come back for repeat procedures, or finally might end up requiring a bypass surgery. So, for example, distal vessel diseases, mid-LED to distal LED diseases, those are the ones that we tend to use a lot of drug-coated balloons. Okay.
Well, thank you. So a lot of us is still based on our own personal experience and anecdotal. So one of the audience was asking, do you have long-term results? Because ultimately it's the outcomes, long-term outcomes that matter when we use DCB in our patients. So do you have any long-term outcome results of all those cases that you have treated in your center?
Out of the number of cases to whom I've already applied the device, I have performed 2 Recoro. One of those I presented here earlier, but since the biolimus-coated balloon was just marketed in our country for the past 11 months, so I can't present any big data on that.
And you mentioned in one of the cases that there is a positive remodeling of the vessels. Can you elaborate on that? One of the members here is quite keen to know.
Yeah. Applying a DS or or any intervention to the coronary lesions, there are always two things. First is the acute gain and the late lumen loss. But in some lesions where we can find the extension of the atherosclerotic plaque, applying such technology with the anti-proliferative drug can sometimes yield a bigger luminal diameter at the follow-up. So instead of having a late lumen loss, meaning that the vessel diameter shrinks, we expect that the vessel size gains even better. It means that it gets larger. That's what I mean with positive remodeling.
Maybe I can ask Dr. Chiang again. So what do you think is the mechanism of the benefits of DEB, drug-coated balloon, in in-stent restenosis as in the Bio-Ascend trial? Is it because of the drug that was delivered, or is it because of the remodeling, or is it because of the vessel enlargement and so forth? So what is it about the DEB that can bring about this benefit that we observe in ISR, not just in Bio-Ascend, but most of the other trials as well?
So I think based on the data presented by Dr. Gao, we can see there's hardly any late lumen enlargement in the patients included. So I think ISR is different from the de novo lesions. So mainly the mechanism maybe just a drugs to inhibit the intimal hyperplasia. Late lumen enlargement maybe it's higher possibility to be seen in patients with de novo lesions, not in ISR lesions.
So maybe I can ask Dr. Gao. So in the biolimus eluding balloon here, what is the rate of elusion? How long does the drug? Are there preclinical study to tell us how long the drug stays on in the vessel wall, and how soon is all the drugs eluded from the balloon?
I think biolimus-coated balloon, I think, is a good balloon, coated balloon, because we use it in clinical trial. Sometimes we will meet a heart lesion, And if the time a little longer than usual, for this kind of balloon, you can find the result is good. So I think for biolimus-coated balloon, drug absorption and the duration is a little better than other other numerous balloon. I don't have a long-term data, but I think we can find the result in the follow-up study. That's all.
Certainly, still a lot to be answered, but we are, of course, encouraged by the current evidence that we have. Thank you very much. So I think having heard all the presentations and the discussions, perhaps we can go home today with the following key learning points here. Firstly, I think it is reasonable to say that the new biolimus-coated balloon does prove efficacious in the treatment of patients with in-stent restenosis in a manner that is similar to the paclitaxel-coated balloon that we know about. And there is, of course, potential for use of DCB in general for large vessel disease, but we still need a lot more evidence and lot more understanding of how to approach this sort of stenosis. And finally, I think the safety and feasibility of biolimus A9 DCB in small vessels, bifurcation side branch lesion has been shown to be established in real-world practice based on Dr. Dasso. Most of us still do not have access to this technology, but we certainly hope that we will have the opportunity to use it in future. So, but anyway, the future seems pretty bright to me, and I hope that you will keep it in your radar as you go about in your daily practice. Thank you very much to all my panelists and the audience for attending this afternoon symposium.